Today we're going to talk about overtraining and overuse injuries, specifically overtraining syndrome. And overtraining is essentially a condition in which, despite high volume of training, an athlete experiences a decline in performance. So they might have excessive frequency, volume, or intensity of training, resulting in abnormal fatigue, when normally you would expect an improvement in performance with that increase in volume or intensity or frequency of training. However, they might experience symptoms and even a decline in performance. Some of the symptoms include decreased appetite and weight loss, muscle tenderness, regular head colds, sleep disturbances, elevated heart rate and blood pressure, occasional nausea, and higher VO2 at lower submaximal workloads. So you can see there's an exaggerated response from the body to try to meet the demands of training. If you've ever been overtrained, you know that it feels pretty terrible. So the only way to really prevent overtraining is through rest and recovery or even low intensity exercise. Some of the other impacts of the symptoms from the previous slide, such as sleep disturbances and regular head colds and decreased appetite, they can also cause suppression of immune function and increased sympathetic nervous system activity. So that's an increase in norepinephrine and epinephrine responses in the body, which is why there could be an increase in heart rate and blood pressure at lower intensity exercise. Also an increase in levels of stress hormones such as cortisol and sometimes even protein breakdown, which inhibits muscle hypertrophy or that enhancement in muscle recovery. So we've discussed some of the symptoms of overtraining syndrome. However, we haven't really discussed prevention. So how do we keep ourselves from getting overtrained in the first place? Well, one great way to do that is to have cyclic training. Some people might call this undulating periodization. It's not necessarily the same thing. They're not synonymous. But cyclic training would be training easy, moderate, and hard, and basically adding variety into your program where you're not always training hard. You do have light days and moderate days. If you do have 1 to 2 hard days of training, you want to follow those up with easy or moderate days. We also have to be very careful of our diet. While we don't give specific diet recommendations, we do need to be aware that our athletes need to replete their carbohydrate stores. And so they need to replenish those carbohydrates, especially those endurance athletes, immediately following a workout, and really take care of their body with rest and recovery and a good diet plan after they finish their hard workouts. So what is the fitness professional's role in preventing overtraining? Should we be able to identify it? Should the client have to identify it or the patron have to identify it? Well, I think our role in overtraining is really to prescribe adequate exercise, adequate volume of exercise, and to notice when our client may be a little bit more fatigued that day. For instance, while it's not overtraining, I had a client once who would come in from overnight surgeries, who was a cardiovascular surgeon, and I would adapt and modify my workout program that day based on the amount of sleep that he had had that night and how he had taken care of his body the rest of the week. There was a definitive difference in his exercise performance during our training programs on nights where he had not gotten much sleep or had been called out in the middle of the night for an emergency surgery. So as you guys might recall, there's a cumulative injury cycle where if we have repetitive overload and repetitive trauma, we're going to have repetitive injuries, and we're not going to be able to fully recover until we take care of those. We know that repetition can lead to adhesions, which can lead to overcompensations and further injury or strains and sprains, which can start the cycle all over again. So when we have that repetitive tissue overload, we have that micro trauma, we're not able to repair, and we deteriorate our connective tissue. There's a great diagram on page 276 in your exercise, client-centered exercise prescription book if you'd like to take a look at that. Some common specific overtraining injuries you guys may have had or have heard of: rotator cuff tendonitis, shin splints, groin pulls, jumper's knee, and then there's some areas that those are specific to. So for instance, if you have swimmer's shoulder or an impingement of the shoulder, it's often, the tendon often affected is the supraspinatus. So when we're prescribing exercise for injured clients, we want to make sure that we are very careful with how we progress them through exercise. And I know many of you have had this issue with your clients who have started off with injuries or surgeries this year, and you've had to work around those. So you might be familiar with or able to apply some of this information with what you've already done this semester with your clients. So our first thing is inflammation control and pain management. So we're going to use the RICE model: rest, ice, compression, and elevation. Okay, so what can we say about giving out medication? Well, we could say that NSAIDs or medications like ibuprofen are non-inflammatory or anti-inflammatory and might decrease the swelling, but we probably should not go beyond that in prescribing medication to our clients. Okay, so we should often, if we're looking at pain management and medication, we should refer out to a doctor or physician. The next stage is stage 2, recovery and repair. When we're looking at recovery and repair, we're looking at preparing to return to activity. So in stage 1, we have really limited involvement because that's going to be just getting them back to the point where they can put pressure on that joint or utilize that joint. And that's really more of the physician or therapist's role. With recovery and repair, what we're trying to do is reduce muscle atrophy, and we're going to prevent loss of range of motion. So we want to still be using the body to prepare for return. We're not adding strenuous activity to the body, but we are trying to prevent that loss of range of motion, repair that collagen, and reduce atrophy by remaining somewhat active. So our initial action is going to be to limit all activities to pain-free range of motion. So we should be able to have them do anything that they can do within pain-free range of motion. That's basically our goal. So this takes a lot of talking with our client, back and forth, seeing how they're feeling, making sure they're being honest with us about their pain, and then possibly finding ways to limit pain in different motions that we are prescribing. So if we're prescribing exercise and there's pain when they bend at the knee, we do straight leg activities to still work those muscles around the knee joint. Maybe we put a band at the ankle so it's not quite up at the thigh and the knee area, and we can still do exercises for the lower body musculature without moving them through that painful range of motion at the knee joint of knee flexion. And stage 3 is more functional progression and remodeling. So with functional progression and remodeling, that's when we start focusing on proprioception, focusing on having them neurologically recruit those muscle groups around that joint and those tendons, maybe utilizing a foam pad or one-legged balance exercises to really focus on proprioception, and then moving on to body weight exercises or bands or exercises where we're more moving them through the range of motion, making sure they're pain-free and they're behaving more passively. And then we move on to adding an external load when they're ready to move through that pain-free range of motion with an external load. So the pain scale for overuse injuries range from 1 to 7. So 1 would be stiffness or mild soreness after activity. That usually disappears within 24 hours. With phase 2, we can relieve the activity with a warm-up, and typically our pain might last up to 48 hours. With all the way to phase 7, we might have disrupted sleep, and the pain intensifies with activity. So if we're looking to try to quantify someone's pain, we could use this pain scale of phase 1 to phase 7, and kind of see where they're at as far as pain goes. We would not want to work them out if they're more than phase 3 specifically, because they're going to alter their activity in phase 4, and they already have mild pain noticed with daily activities. Now, that being said, we don't want to push through pain with the mild soreness and stiffness, and we're really going to have to focus on a good warm-up and prescribing exercise that specifically moves them through pain-free range of motion and does not cause them more pain than they were in when they came. So in stage 2 specifically, some specific things that we can do for that recovery repair stage when we're preparing to return to activity. We would want low load. We don't want excessive stretching, but we do want some range of motion work, flexibility work, but we do want low load. And we also want to work out at different joint angles submaximally for isometric training. So isometric is a great way to train in stage 2, where you're not moving through a range of motion or requiring the body to coordinate a functional movement, but we're doing more stabilized training at different angles to work different areas of that muscle group. And if we have isokinetic, it should say, we would do 30 reps over 2 to 3 sets, no or light weight. So we're going to do about 3 sets of 10 with no or light weight during this stage. When we've done some submaximal isometric lifts and some isokinetic lifts, we can go to maximal isometric training. So we could do maximum force that you can stabilize, or maximal endurance that you can stabilize your body with an isometric exercise such as a plank or a wall sit or something like that. And then we want to go into full range of motion with isokinetic, gradually increasing our weight and adjusting our repetitions. With that, we also want to stretch 2 to 3 times a day, because our stretching effects last about 4 to 6 hours. And so if we stretch 2 to 3 times a day, we'll maintain our flexibility and range of motion throughout the day. And we want to progress very slowly over 3 to 6 weeks time, starting with about half of previous intensity. Now that's the intensity that you were at before you had the injury. So we want to make sure that we progress our client slowly, we don't move on too quick, and we have a longer warm-up and cool-down. So we may have more than just the 5-minute warm-up or the 5-minute cool-down, but we may have an extended warm-up or cool-down. We may want to focus on that area that we're trying to recover and focus on incorporating exercises that are very light or no weight, and focusing on really activating and firing those motor units for that muscle group around that area before we progress to anything more strenuous. But we also want to focus on isometrics and isokinetics in this stage. Now, stage 3 is focused on functional remodeling and progression. So we're really trying to get them back into their prior state of training, and we're also trying to make sure that we prevent re-injury. So with functional progression, we want to work for about 2 to 3 times a week, and we can utilize our full range of motion to strengthen those muscle groups. So we could look at adding an external load, varying the resistance training with different exercises, and really trying to condition the client to get back to where they were prior to injury, and make sure that we're reteaching them the movements correctly so that they do not put themselves at risk for re-injury. We also want to emphasize specificity, so we want to get back to specifically what the client is training for. Now, if you're going through a basic rehabilitation program and you're not working for something specifically, as many athletes are, this might just include improving your VO2 max and aerobic performance and making sure your movements are correct and you have appropriate muscle balance, so they're working on posterior, anterior, agonist relationships and what those should look like and how much strength they should have. But we want to emphasize specificity for our athlete or for our client that's just trying to get back to activities of daily living. We also might start to incorporate power-oriented activities during this final stage to progressively increase eccentric strength and power. Those are very important for deceleration activities and for stabilization, and we want to make sure that we're training to be able to do those activities to prevent re-injury. We also want to make sure we're focusing on our neuromuscular function still during this time. So whereas we were maybe isolating and creating an environment that enhances proprioception in stage 2, we might be adding in more complex coordinated movements during this time to make it more proprioceptively challenging and challenging our balance and coordination and agility. So this also leads us to the topic of tapering. So tapering is the one way to prevent overtraining and injury. Tapering is essentially the act of not necessarily detraining, but making sure that intensity and volume of training are reduced to provide time for the body to prepare for performance. You often see this when people are training for marathons. You also might see it during strength and conditioning when somebody's preparing for their competitive season and they want to be at full energy for their competition. We know that peak performance requires maximal physical and physiological tolerance for the stress of the activity. So periods of intense training could reduce our muscular strength and our performance capacity. So this period of reduced volume is designed to enhance our ability to perform for a competition or a specific event. So it's not necessarily detraining, okay? It's really a time of the body replenishing glycogen stores that were depleted during high intensity training and repairing injured tissue so that it's at its optimal level for peak performance, because oftentimes intense training can decrease performance capacity, and we need that time, our body does need that time to replete those stores and to repair that tissue and to really feel at full steam for competition. This typically lasts around 2 to 3 weeks. One other component we can talk about is detraining. We've talked in length about overtraining as well as tapering. We could also complete detraining, which is essentially a cessation of regular training. We know are no longer training. We have little change in strength and power during a time of detraining. Many times it takes a little longer for us to lose that strength and power when we detrain. However, there are immediate drops in muscular endurance and cardiorespiratory fitness, oftentimes with detraining. So I've heard it said that some people can lose about 50% within 2 weeks. Some of the other research shows that it's a 20 to 30% drop with 20 days of training. Probably the more accurate assumption would be that it's about a 20 to 30% drop with 20 days of training, which is quite a bit from if you're thinking about how hard you train for cardiorespiratory fitness. So this is something that you'd want to maybe say to someone who's thinking about taking a few weeks off of the gym. A week is good, but 20 days or 3 weeks can cause pretty big decreases in cardiorespiratory fitness. And then within 2 to 4 weeks, we can see a 40 to 60% drop in muscular endurance. Now, this is just an average for individuals. It's not true for everybody. We know that detraining and training happen at an individual rate on an individual basis based on genetics and previous performance. The longer you've been training, probably the less that you seem to lose, but that's just a relative assumption. Now, flexibility, while it's lost quickly, it's also regained quickly. So that is something that we can think about if we have stopped stretching and lost quite a bit of our flexibility. It's something that we can actually work on and improve upon more quickly than, say, any of these other variables, which take longer to change. And those variables that experience little change from detraining, such as muscular strength and power, also probably take a little longer to change in the positive direction as well. So those are some things to consider.